Welcome everyone. Today we are going to discuss surgical dislocation of hip joint. This is also known as Ganz approach. Surgical dislocation of hip joint was described by Ganz et al. And it provides full access to the acetabular rim, labrum and the femoral head. It preserves the femoral head blood supply by protecting the deep branch of the medial circumflex femoral artery. Now, in a standard posterior approach, the short external rotators are cut. This deep branch of medial circumflex femoral artery crosses the obturator externus muscle from below and is thus violated in the standard posterior approach. However, in the Ganz approach, the short external rotators are not cut. So, this approach preserves the deep branch of medial circumflex femoral artery. Procedures which use surgical dislocation of hip are open reduction and internal fixation for femoral head fractures, procedures for femoroacetabular impingement like acetabular labrum repair, acetabuloplasty, which is reshaping of the bony acetabular rim, and femoral osteoplasty, which is removal of bony bumps as in a cam type impingement. Other procedures are reduction osteotomy and chilectomy in Perthes disease, open treatment of slipped capital femoral epiphysis, hip arthrodesis, and articular cartilage defect reconstruction of the femoral head. Coming to the technique of surgical dislocation of hip. The incision is a standard Coker-Langenbach incision, which in the distal part is a mid-lateral diaphyseal incision, which is curved posteriorly from the greater trochanter towards the posterior superior iliac spine. This is followed by splitting of the iliotibial band and splitting of the gluteus maximus along the line of its fibers. A modified Gibson approach is also sometimes used, which is a straight incision. The incision is followed by splitting of the iliotibial band distally, and proximally this split is extended along the anterior margin of the gluteus maximus, and the gluteus maximus is retracted posteriorly. This is followed by internal rotation of the leg to identify the posterior border of the gluteus medius muscle. The postero-superior margin of the greater trochanter is exposed, and the exposure is extended distally till the posterior border of the vastus lateralis ridge. This is followed by a trochanteric osteotomy, which is around 1.5 cm thick, which may be transverse or a step cut osteotomy. Care has to be taken that the proximal part of the osteotomy should exist anterior to the posterior most fibers of the gluteus medius insertion. This protects the profundus branch of the medial circumflex femoral artery. This is followed by anterior mobilization of the greater trochanteric fragment, also known as flipping of the greater trochanteric fragment. So this osteotomy is also known as trochanteric flip osteotomy. Further mobilization of the greater trochanter requires release of the remaining gluteus medius fibers and sometimes release of part of the piriformis muscle. For exposure of the joint capsule, the leg is externally rotated and the fibers of gluteus minimus over the joint capsule are released. The leg is further flexed and externally rotated to expose the joint capsule fully. Now, a Z capsulotomy is performed in the joint capsule. The first limb is along the long axis of the femoral neck up to the acetabular rim. This avoids injury to the deep branch of the medial circumflex femoral artery. The antero-inferior limb is then made, and this is made anterior to the lesser trochanter to avoid injury to the main branch of the medial circumflex femoral artery. The anterior superior limb is made parallel to the acetabular rim or labrum, reaching up to the piriformis tendon. This is followed by further flexion and external rotation of the limb to dislocate the hip. Now the acetabulum and the femoral head is under view, and manipulation of the leg can provide 360-degree access to the acetabulum and nearly 360-degree access to the femoral head. Now the desired procedure is performed and the hip is relocated following the procedure, and the capsule is repaired. This is followed by reattachment of the greater trochanter with 4.5 mm cortical screws, and this completes the procedure. Coming to the complications of the procedure, they are fracture of the greater trochanter and non-union of the trochanteric osteotomy. There may be sciatic nerve injury, damage to the intra-articular structures, and heterotrophic ossification. The procedure may also cause damage to the vascularity of the femoral head and avascular necrosis of the femoral head. However, this is much lesser compared to the standard posterior approaches. So friends, this was a video describing the safe surgical dislocation of femoral head or the Ganz osteotomy. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.